Thank you very much, Tom. Hopefully you can all hear me nice and clearly. So I'm going to give you a very quick whistle-stop tour through the principal changes that you will see when the updated National Clinical Guideline for Stroke is published. The last edition emerged in 2016, so we're 7 years on. And I think probably from what I'll show you very quickly is the significant way in which the knowledge base for stroke has moved on in that relatively short interval. These are my declarations. I have various fingers in various academic pies and so on, all of it, of course, in relation to stroke. I am also going to respect the time-honoured maxim that when presenting, you can only possibly expect your audience to remember 3 things. So I'm going to stick to 3 things. There are 538 recommendations in the updated guideline, and if you've got time, I'll start with the first of those now, of which 300 have been reviewed, updated, or rewritten entirely. So it is, in fact, only a partial update, although it hasn't felt like that. And there are some important changes to the guidance that I really haven't got time to go into this afternoon. For example, a complete reversal of the recommendations around the management of stroke in association with patent foramen ovale, and some big changes in relation to drug management and secondary prevention, which I won't be able to go into in much detail. But we're going to look at just 3 areas where practice is likely to change substantially in the aftermath of these guidelines. First is acute care, hyperacute management and reperfusion. The second is the secondary prevention of stroke. And the third is the progress that has been made in the evidence base regarding rehabilitation and recovery from stroke. So let's begin then by looking at what's new in acute care. First of all, before we turn to thrombectomy, let's consider the manner in which the evidence has advanced in relation to intravenous thrombolysis. And there have been several significant randomized controlled trials since 2016, which have all looked at extending the time window for conventional intravenous thrombolysis from what we've come to accept as the outer margin at 4.5 hours, all the way up to 9 hours since last seen well, and including trials of thrombolysis in patients waking up with stroke. Now, 14% of all stroke that presents to hospital is a wake-up. So that is a big group of patients for whom we have been uncertain about what to do for the best before now, including studies that have timed the wake-up of stroke by this mechanism, waking up to 9 hours from the midpoint of sleep, which I'm sure for you all is a very easy commodity to call to mind about the middle point as to between when you went to sleep and when you woke up. But just to illustrate the fact, if a patient retired to bed at 11 p.m. the previous evening and woke with their stroke at 7 a.m., then 9 hours from the midpoint of sleep would take that patient up to 12 midday after of the day that they presented. So this obviously stretches the time interval to include pretty much most of the morning, during which time the patient may come to light, be discovered, and subsequently present to hospital. So it encompasses a large proportion of those patients who wake up with stroke. And those patients are principally selected using perfusion imaging in this randomized controlled trial conducted principally in Europe, mostly using MRI. But for all practical purposes in the UK and Ireland, we're talking about selection using CT perfusion imaging. So we're going to see a dramatic increase in the use of perfusion imaging, mostly CT, in identifying those patients who at the moment are regarded as either of unknown onset or of wake-up stroke, because they may potentially be eligible for intravenous thrombolysis. And the agent that we can use in theory at least, from a randomized controlled trial, as long as a lot of observational data, could be tenecteplase just the same as alteplase. It took the cardiologists about 3 weeks to work out whether the two of those were equivalent through enormous multi-center trials, but it's taken the stroke world a painfully agonizing 15 years to work out whether tenecteplase and alteplase are equivalent. But we have now confirmed with confidence that they are. Not that that helps us any, because at the moment there is a worldwide shortage of tenecteplase, which is likely to persist for at least another 18 months. So the immediate consequence of this is that we're likely to have the only option of continuing to use alteplase. But of course, the great benefit to tenecteplase is it's a single bolus injection. So you can be sure that the dose is given, particularly if you're packing the patient off somewhere else, for example, for a thrombectomy. And as well as more people eligible for thrombolysis, there's going to be a big increase in the number of people who will be regarded as eligible for thrombectomy. First and foremost, those with vertebrobasilar stroke, principally basilar artery occlusion. Again, an area where an unusual degree of uncertainty has persisted in trial data up to now. Two large and convincing randomized controlled trials from around the world with approximately similar designs, looking at people within 12 hours of onset with angiographically confirmed basilar artery occlusion, as you can see on the slide here in the left panel, and who have both significant neurological deficits but also no large-scale evidence of established infarction with hypodensity in the brainstem or the cerebellum. So now we have with confidence evidence that at least patients below the age of 80 should be having intravascular interventions for basilar artery occlusion. Of course, when we come to the anterior circulation, the carotid circulation, and that was the big change in 2016, the introduction of thrombectomy as a recommended treatment. And the typical patient recommended according to the 2016 guideline is like this. Someone with an acute anterior circulation ischemic stroke who may or may not have been treated with thrombolysis because of exclusions. And in the UK, that applies to about half of all the people who receive a thrombectomy. They are, in one way or another, excluded from receiving thrombolysis, who were previously pretty much independent and not relying upon anyone else for ordinary daily activities, with a disabling neurological deficit, who can be treated within 6 hours of known onset. And that would be the eligibility according to 2016. And there on the angiogram you see a proximal middle cerebral artery occlusion, and that would be typical of the sort of patients eligible for thrombectomy. And of course, as Nicolas suggested, a larger proportion than average of these patients have a cardioembolic cause. Going beyond that 6-hour limit has until now been dictated principally by whether or not we identify any salvageable brain tissue, or in the terminology of NICE, the potential to salvage brain tissue. And so the typical patient who would be treated beyond 6 hours up to now would be someone who showed the sort of CT perfusion deficit shown in the upper panel on this slide. On the left-hand side of the upper panel, you'll see this tiny little purple blob, which is the core, which is conceptually regarded as the bit that's going to inevitably be lost. And to the right-hand side of that upper panel, you'll see the bright green is what's conventionally called the penumbra and regarded as the bit that could be salvaged. So to perform a thrombectomy, according to previous evidence, you'd need that sort of profile of imaging in the top panel. A tiny core, not much brain about to be lost, probably less than 10 millilitres, and a large penumbra, a large area of salvageable tissue. But of course, it raises the question about what happens if you look at a patient beyond 6 hours and they've got the lower sort of profile in the lower panel. Instead of a small core, you've got a very large core, the large purple blob on the left side there. And the green blob, the penumbra, is not that much bigger than the purple. There's not much mismatch between core and penumbra. Now, typically, those patients will have been excluded from thrombectomy precisely because of that reason, because the core was too large. And you can go further. Rather than needing elaborate advanced imaging techniques like CT perfusion, which do require skilled interpretation, which isn't in the hands of all our radiology colleagues, particularly out of hours, You might just look at the plain CT scan and identify the bits of brain that look like they're inevitably going to be lost because of the development of hypodensity. And you can carve up the middle cerebral artery into 10 segments, 4 deep sections and then 6 superficial sections of the middle cerebral artery. And you can tot up the number of areas out of that score of 10 which look like they're inevitably going to be lost because of hypodensity. And you can subtract that from 10. That's called your aspect score. I hope that for all of you, your aspect score is 10, but many patients with developing infarction, particularly beyond 6 hours, of course, you're starting to deduct some of those areas from their score of 10. And so what happens if you go all the way down to, say, 3? A large wodge of your middle cerebral artery territory looks like it's inevitably destined to be lost. You'd have a very large purple blob on your CT perfusion scan. Well, what we know from 2 randomized controlled trials, again, worldwide, published a little more than a month or 2 ago, is that those patients, too, benefit from thrombectomy. So in other words, you don't need just that tiny core. You can have a big core, 80 mils, 130 mils, and you can have only a very small degree of mismatch between the purple and the green, maybe just 15, 20 mils. Being identified as salvageable by the imaging. Yet, randomized trials have shown that those patients similarly benefit from thrombectomy. So the big change in the national guideline is a very substantial expansion of the eligibility criteria from thrombectomy, from those highly selected patients within 6 hours to really out to 24 hours with anyone with this sort of imaging profile. You'd look at this sort of CT scan and you'd say, well, heck, this matters are far too well advanced for thrombectomy or indeed anything to be beneficial for this sort of patient. Whereas these are the sort of patients that were randomized in the trials and shown to benefit. But I notice a look of skepticism across your faces about the magnitude of the benefit from that sort of intervention. Surely the horse has bolted. Surely it's too late to benefit. And of course, it's true to some extent. The magnitude of the benefit is less with later intervention and with lesser degrees of penumbra. That's certainly true. But of course, the magnitude of benefit of thrombectomy is so large that you can trim away at that benefit and still be left with really quite significant advantage to the patient. And this is essentially what these trials have shown. So if we look in the upper 2 bars, the overall impact on disability from thrombectomy within 6 hours in people who did not have any sign of infarction on their CT scan. And as you can tell from the bottom of those 2 bars, you're getting to a point where nearly half of the patients who received thrombectomy in those trials, those early trials, are left independent after their stroke, not needing the help of another person. What you see in the bottom 2 bars is the other cohort of people, those beyond 6 hours, who already have visible infarction on their scans. What you can see is an almost similar increase in the proportion of patients who are left independent. 30% of patients receiving thrombectomy in those trials were left independent, compared to 11% who were randomized to not receive thrombectomy, an absolute difference of about 19%, an NNT of perhaps 5 or so. So such is the magnitude of advantage from thrombectomy that even if you do it late with a big established infarct already, you're still conferring substantial benefit to the patient. And that was something that was suspected from the other evidence and has been demonstrated by these trials. But what you'll also see from the red vertical line midway along is the median disability for people who've received even thrombectomy. And as you can see in the bottom half of the slide, the median disability for people who've received thrombectomy under these circumstances is still needing the assistance of another person with ordinary everyday activities. So there's a paradox. Still a lot of benefit, but still a lot of people left with considerable disability. So all the therapists who thought they'd be thrown out of work by the advent of thrombectomy can be amply reassured there's still going to be a lot of rehabilitation that needs to be done, and we'll return to that in a moment. So the other topic, the second topic we thought we'd cover, is looking at secondary prevention. And if you have to remember just one thing about secondary prevention, we're really talking about more intensive degrees of secondary prevention. So when it comes to antiplatelets, there have now been randomized controlled trials looking at combination antiplatelet treatment, either clopidogrel plus aspirin for 3 weeks or ticagrelor plus aspirin for a month. And both of those, in people who are at relatively low risk of bleeding at least, confer significant benefit over monotherapy with either of those agents. But you can have too much of a good thing. Since 2016 edition, we've had one randomized trial of triple therapy, saying if 2 is good, 3 must be better, showing that if you hit that sort of level of antiplatelet treatment, you just get more bleeding for no advantage. So we're probably butting up against the upper limit of benefit from increasing our antiplatelet treatment, and certainly by giving it for a shorter time appears to reduce the risk of bleeding as an adverse event. Secondly, we're looking at lower target cholesterols, a randomized trial looking at a lower target for LDL cholesterol, LDL below 1.8, which is pretty much equivalent to non-HDL cholesterol below 2.5, which is a much more accessible measure, and intensifying anti-cholesterol treatment in order to achieve those lower targets. And we'll have a look at that in a moment. And then lower target blood pressure. The difference with stroke compared to other signs of vascular disease is there is randomized control trial evidence in stroke that the lower the blood pressure, the greater the benefit. There appears, in fact, in stroke to be no floor effect. And so the recommended levels for target blood pressure in the National Clinical Guidelines are lower than you would read in NICE. We're looking at clinic blood pressure below 130/80, or better still, home blood pressure consistently achieved below 125/75. And of course, these arguments for intensifying secondary prevention aren't lost on the chief medical officers of all the 4 UK nations who combined together to write this editorial in the BMJ, extolling the virtues, as if newly discovered, of preventing recurrent events in people who've already suffered an event. 25% of all stroke is a recurrent event. So these people are already walking the streets of London and everywhere else with a big flag over their heads saying, I'm thinking of having another stroke. And so anything that we do to intensify treatment for those people reduces the risk of recurrent stroke. So they are a target population for intensive secondary prevention. And of course, the NHS, at least in England, have combined with the academic health sciences networks in the Accelerated Access Collaborative to try and improve and accelerate access to greater intensity cholesterol-lowering treatment. Not just through the use of things like atorvastatin instead of simvastatin or pravastatin, but also through the use of higher doses at 80 milligrams of atorvastatin, and also through the early and prompt addition of things like ezetimibe, which is enjoying a renaissance as adjunctive treatment with a statin. And 2/3 of the people in the randomized controlled trial I referred to a moment ago were put onto ezetimibe in addition to high-intensity statin. And of course, so there's a role for ezetimibe, and of course the injectables, inclisiran, hailed as the potential to save 150,000 strokes and heart attacks over the next, was it 5 or 10 years, over an arbitrary period, because it leads to further substantial reductions in LDL cholesterol when added in top of statin therapy for the for the price of 2 injections a year at £110 a year. So the Accelerated Access Collaborative is one of its objectives is to increase the uptake of inclisiran. For example, on our stroke units, in our TIA clinics, we could all give everyone a jab of inclisiran before they get the bus home and start the ball rolling with intensive cholesterol-lowering therapy. So, and then the third area that I was going to cover would be the progress in the evidence base for rehabilitation. Significant advances since the last edition in 2016 in the evidence base regarding both the dosage and the intensity of rehabilitation therapy. It's fair to say that the rehabilitation academic and scientific community across the world has stepped up to the challenge of matching the standard sort of pharmacological approach in proving about the effect of the dose and intensity of rehabilitation. So for motor recovery, patients who've got motor recovery goals, the recommendation in the guideline is daily therapy for up to 3 hours a day. for motor goals, and in fact daily activity for 6 hours a day. So it's turned full circle from Roald Dahl, who demonstrated in his N of 1 that intensive, prolonged, sustained motor rehabilitation led to meaningful goals, that we've now discovered this, and it's now recommended for all our patients with motor goals, but also those who require language rehabilitation. Supplementing the use of face-to-face or traditional speech and language therapy, if you like, with assisted technology, iPads and so on, and looking at a far greater level of speech therapy that has traditionally been delivered to patients, looking at more than 20 or even more than 50 hours of therapy during the chronic phase of speech and language therapy. Is that what's being delivered at the moment? Well, no, in fact, on 2 levels. Firstly, if you look at the left-hand panel, there's the amount of physiotherapy currently being delivered in the National Stroke Audit SNAP. About 70% of days, some therapy is being delivered. On average, about 35 minutes of therapy. 2 minutes. Okay, 2 minutes of therapy left. But of course, we're moving much more swiftly now towards delivering therapy in people's own homes rather than in hospitals through early supported discharge. And if you look on the right-hand panel very quickly, before I change the slide, far smaller levels of therapy being delivered to people in their own homes compared to in hospital. And the same for speech and language therapy. So we've got a long way to go before we are delivering the sorts of levels that are recommended in the guideline. And of course, we've got a nice rehabilitation guideline coming out at the end of the year, probably in October. But the nice methodology confines them to looking at cost effectiveness in areas with randomized trials. The advantage of doing a national clinical guideline is that you can look at areas where we know the evidence to be weak, yet we know there are controversies in practice. And we've looked at rehabilitation potential, return to work, post-stroke fatigue, and life after stroke. And of course, if you talk to people with stroke, they say these are important. They want to be able to get back to work when only half of them do after a stroke. And they are often crucified by fatigue, which is one of their most disabling symptoms. Yet the evidence base in these areas is very weak. But we do have consensus guidance in the guideline, which will be online only at www.strokeguideline.org. It will, of course, as would be traditional, be available on your iPhone or whichever phone of your choice. You might even be able to see the text on your Apple Watch. You can, if you're traditional, still download the PDFs for printing. And we're particularly pleased with this aspect in that we've worked with patients and patient advocacy groups to update the patient and carer guide, which is now called a plain language summary, which should be used widely to educate patients and their families about what the science is saying should form the basis of the treatment of their stroke, both in medical aspects and in rehabilitation. So, at the risk of outstaying my welcome on the podium, but sticking to those 3 things to remember from the updated National Clinical Guideline, a big expansion of eligibility for reperfusion therapy, principally through the use of advanced imaging, more aggressive secondary prevention to reduce the risk of recurrent stroke, more intensive rehabilitation at hospital and particularly at home. And if you'd like to all club together on Tuesday, the 4th of April, next Tuesday at midday, try to crash the website by all logging on at once in order to look at all the other fascinating aspects of the National Clinical Guideline that will be available to you from that date and time. Thank you very much.